Welcome, I'm Dr.Anoop Kohli, Senior Consultant Neurologist at Apollo Hospital, New Delhi. I'll be taking you in brief about a vast, very intricate and yet a very common topic known as epilepsy. Now, very briefly defined, epilepsy is an abnormal burst of electrical activity from the brain. It can occur from the whole brain or it can occur from a part of the brain. Now, the manifestation of epilepsy would therefore be in how much of the brain and which part of the brain is being involved by that abnormal electrical activity. If it involves the whole brain, that's what you see as a generalized tonic-clonic seizure. If it occupies only a part of the brain, and I must excuse myself that I'm using actually a hologram of the brain, which is for future research actually to study the deeper parts of the brain, but I'm taking the convenience of using the hologram to show you that if, although these are for different purposes, if the current arises from this part of the brain and this represents, let's say this is the left side, the right part of the right hand of the brain, then the patient is likely to manifest a movement of the right side. The amount of spread will decide whether he will be conscious, unconscious, whether he have a loss of speech, and if it spreads, he might actually fall and then generalize. So that's the common generalized seizures. Most generalized seizures may actually fall into what are genetic seizures, although you can have a generalized seizure due to any reason. Toxins, high fever in children, in old age you can have it. You can have it of insults of person who's been on fasting for a long time, very high fever as I said, binge drinking, it can all cause it. So that is the basic phenomenon of epilepsy, that it is an abnormal current given by the brain, and the brain we know is absolutely an electrical organ. Most of the electrons are on the surface of the brain, and within them are the various connections. So that is epilepsy. As I said, if it involves a part of the brain, it can even come as a blank attack. The person sort of goes into a dreamlike state. It can come as an automatic attack, supposing it's in the temporal lobes. The temporal lobe will be somewhere on the inner side of this. If it's in the temporal lobes, then you will have a different attack, like an automatic behavior. There will be lip movement, there will be blinking, and then of course you can have focal epilepsy of all types. So I'm just taking you into brief of what epilepsy is, and now here is what I'm trying to show you are some of the rhythms. Now the electroencephalogram is nothing but an electrical record of the brain, just as the cardiogram is an electrical record of the heart. So we have the so-called normal rhythm, which we call as alpha, beta, that's the terminology, beta, theta, etc. But what is pathognomonic, for putting in very simple terms, of a seizure is a sharp spike or repetitive spikes, as you see in this record. Now this record is not representative of what I want to say, but I'm just trying to tell you that if you have such a run, then it means that it's a run of population of neurons that are firing intermittently. So that's an epileptic run. And you can have runs like this, which could be epileptic, which could be brain activity due to drug toxicity. Now, how do we know whether a patient has epilepsy or not? One is the clinical history. When the patient becomes unconscious, there's tonic-clonic movement. Most of the times the attacks would be repetitive. So the attacks may not be very clear. I mean, he just blanks out for 2 or 3 seconds and he comes back. But each time he says, before it happens, I get an epigastric rising sensation. I get the same sort of feeling of heat which I can't describe. That's what they'll say. I can't describe it, but I have the same feeling. And then I have perspiration, and then I don't know what happens. If it is typical and if it is repetitive, neurologists think that it is an electrical phenomenon, and they would like to investigate, is it truly an epilepsy? Because that phenomenon may not be recorded, may be taken as hysterical syndrome, or may be taken as psychosis or malingering behavior. Now, the way we take the EEG is pretty simple. Now, if the brain be a globe, as it is, you put electrodes all across the globe. So in a way you have mapped, just the way you map the globe into latitudes and longitudes. So anything you want to find, you say that this longitude and this latitude, and that's how you locate it. So these are pre-decided spots in the brain, and they're standardized. So you call frontal, then you have anterior temporal, posterior temporal, then you have occipital, which is the back of the brain, you have central, you have paracentral. So that's named. So once you know that, and each one of them will start recording. As you see over here, this is a diagram. If you can focus on this is a diagram of the brain, and these are the electrodes, and each one of them is throwing a spike. Now, if you find an abnormal wave in any one of them, and find it consistently, or find it well enough, and it matches with the semiology, then you more or less have localized what form of epilepsy it is. The importance of localizing of epilepsy is that epilepsy actually is a symptom. It's like fever, but whether the fever is typhoid or malaria or a viral fever or something else, so epilepsy is a reaction of a brain in form of abnormal electrical activity. But if you localize it, then you become more sure that part of the brain is causing epilepsy. Now, it can be correlated to lesions that are inside the brain, which you see on the MRI, which is a picture, anatomical picture of the brain, and this is the physiological electrical activity of the brain. So that one way helps you. So if you get something like this pattern, a generalized pattern, which means if you would take all these leads and on one side, all of them are firing together, that's how epileptologist or person who reads EEGs will say that this is a generalized seizure. And if you get it only in one of those leads, then you say, okay, this is a focal seizure. The importance of generalized and focal seizures have a bearing, because some focal seizures can be benign, as in children, which are called as Rolandic seizures. So you have a different spike wave combination on the leads. Generalized seizures in a small child could be part of familial seizures and will go on for 2 or 3 or 5 years. And you also have a drug of first choice for these seizures. So that's the way a neurologist should know which drug to give once he gets an electrical information. The diagnosis of seizures may be decided just by what's happening in front of you, or by what people have seen. These days we encourage our patients actually to take home videos, because it's rare that a patient will have a seizure right in front of you. And as technology has gone, everyone has a smartphone. So everyone has at least a 5 megapixel video camera with him. So that's what we tell them. The moment you have it, it's on the dining table, shoot the child, see what's happening. If you can show us more of that, we know it's epilepsy. We can confirm it with an EEG, and we can further give the drug of first choice. Now, a very small amount of patients can be helped by epilepsy surgery. Now, epilepsy surgery is reserved for those people who would not respond to drugs, or where drug is being given but to the extent of toxicity, and it will be a lifelong giving of drugs which makes the patient so dopey, probably that is not good quality of life. So if you can correlate a MRI picture, an anatomical anomaly along with the electrical focus repetitively, and further show it on further perfusion scans or metabolic scans like the SPECT or the PET, then there is a case of cutting that part of the brain and relieving the patient of a seizure. Now that's a long story. You are not supposed to see that the patient would lose his intellect or his memory or land up with a weakness, unless that small little weakness can be bargained for a lifelong of epilepsy. So this in short, as I would repeat, is epilepsy is an abnormal burst of neurons in the brain that can manifest by which part of the brain is involved. It can come as a focal seizure, it can come as a generalized seizure, it can come as a thought, it can come as an autonomic behavior. And the way she would do it would be, and the many other methods you can further investigate such patients is by doing the EEG. And let me tell you, in spite of all that's happening, the EEG is still the real killer for localizing epilepsy and for classifying epilepsy as experts would want to. That also becomes the basis of the sort of drug which would be the drug of the first choice for that patient. Just to give you one figure, at least 1% of the population may have a single seizure in a lifetime. To have a seizure is not epilepsy. Epilepsy is when you have repetitive seizure, so it becomes a form of a disease that has to be treated. But under high fever, an infant or an old man who's dehydrated, this electrolytemia infection can also have a seizure, but that could be a single seizure and not epilepsy. Epilepsy is the perpetuation of seizures generally correlated with electrical abnormalities on the brain, which you may see on the MRI, or you may conclude by other methods of brain imaging like functional imaging of the brain, as well as the EEG. But the EEG is a very old test, but still is the best method of finding out electricity. And as I said, the various forms, if you have it in all the leads, this becomes a generalized. If you can cone down over here, it becomes a generalized seizure. If you have only one side, then it becomes different. Now there are various patterns and people have to study for years and years to give you the real diagnosis. They are so-called benign spikes in the EEG, and a good epileptologist would know that these are benign and probably do not require to be treated. I suppose with this we conclude the first introduction to what epilepsy is. Thank you very much.
Thank you very much.
Thank you very much.